Hi, this is Elliot Fishman, and welcome to our latest podcast. This is going to be a bit unusual because I'm not going to show you a single CT scan, but this talk is going to be about where CT is now and where an important part of CT is going to be in the future. Now, the title is Liquid Biopsy and CT Scanning, What You Need to Know. Probably most of you want to know what is a liquid biopsy. Well, a liquid biopsy is something that's very, very popular in oncology these days, but really across the spectrum of medicine. It's something that's evolving. It's there in part, but it's going to get much better. And what I'm going to try to do is tell you where we are, where it's going, and how radiology will have a big impact on that. So let's look at a liquid biopsy. It's a blood test that analyzes circulating tumor cells or circulating tumor DNA. So it's always the CTC or ctDNA to assess cancer in a non-invasive manner. It's used for diagnosis, monitoring, and predicting treatment response in various cancers. A more extensive definition from the NCI from their website: it's a lab test done on a sample of blood, urine, or any other body fluid to look for cancer cells from a tumor or small pieces of DNA, RNA, or other molecules released by tumor cells into a person's blood or body fluids. Liquid biopsy allows multiple samples to be taken over time, which may help doctors understand what kind of genetic or molecular changes are taking place in a tumor. A liquid biopsy may be used to help find cancer at an early stage. It may also be used to help plan treatment or to find out how well treatment's working or if the cancer has come back. So what we're saying is, and what I'll focus on in this talk, a liquid biopsy can be from any fluid. It could be from blood. It could be from CSF. It could be from a pleural effusion. It could be from a pericardial effusion. It could be from abdominal fluid. But the way I'm going to think about it and what I'm going to address in this talk is liquid biopsies from blood. And what I'll mainly focus on is the ability to try and detect cancer early. What you're doing with a liquid biopsy, and I'll speak about it, is you'll get blood as if you were doing a typical blood test to look for cholesterol or lipid values. You might think about it as something you would get at your yearly physical. And then what you do is you look carefully at that blood sample to see if there are any markers potentially of tumor. What you're talking about then, a tumor the size of the end of your finger is typically 5 billion cells. What you can potentially do is detect tumors when there are thousands of cells, which means if you pick things up earlier, you may be able to prevent cancer potentially or treat cancer. Even the most aggressive cancers, when they're picked up early, can often be treated. So this would be an unbelievable thing. Now, I'll show you a number of articles, and I want to try to make this talk in a way of teaching you and helping you understand that it's something that's being developed, something that's evolving, but something I think radiologists are not really paying attention to, but they really need to be paying attention to. In this article by Ryan Hurt, the concept of cancer interception is the proactive approach to identifying and intervening early in cancer development and progression to invasive disease. Currently, population-wide screening is only available for a few cancers, typically breast with mammography, colorectal with colonoscopy, and high-res CT for lung cancer in smokers. But those are only 3 cancers. Some of the most common cancers like pancreas and ovary, 2 good examples, have no reliable biomarkers. There's no screening tests available. But can we make a screening test? Blood's inherently well suited as a potential biomarker source for cancer screening because it does get those circulating tumor cells, the microRNA, the cell-free DNA, shed from hidden tumors. Now, there are a number of companies working on this. Two of the biggest companies, Exact Science, where a lot of the original work came from Bert Vogelstein at Hopkins, and Grail, which used to be Illumina. Both of them, you can actually get those tests done. Is not paid by insurance, but they're currently available, and they're undergoing significant testing, and they're being fast-tracked by the FDA, so hopefully they'll come along. Now, when you think about screening tests, you could develop a test for a cancer. Now, if you could develop an ovarian cancer test that was very good, that would be great. But the ideal thing is, what if we could do multi-cancer detection, where you get one blood sample and it looks for between 50 and 70 different tumors? That indeed would be exciting. In this article by Hurt, they looked at multiple cancer detection, and they looked at Grail Galleria, which is one of the bigger ones, and they looked at an 18-month study in an ambulatory care setting. Now, one of the things to remember, in the end of the day, it's not going to be oncologists who order these screening studies. It's going to be internists and GPs. So it's very important for them to understand how things are going to get done. And in this study, they had 44 patients tested, and 17, less than 1%, had positive results. 15 underwent further diagnostic testing. Now, one of the things is at this point, and it will change in the future, I'm sure, if you have a positive test, it doesn't say positive ovary, positive pancreas, positive lung. It simply says positive, and you need to find the tumor. Now, that can be very challenging, of course, because if tumors are so early, they're going to be very small, which can be a real problem. But in this study, out of the 17 and 15 who underwent evaluation, they found 11 cancers, or about 73%, and it included breast, colon, esophagus, lymphoma, ovary, and pancreas. 4 patients had no identifiable malignancy, despite comprehensive workup. So what that means is all of these studies have also false positives. So one of the challenges is going to be, people talk about 25% are going to have false positive studies. And you know how difficult that is. If you tell a patient we're doing a study for screening and the study comes back positive, they're scared, right? I have cancer. But what if you can't find it? Well, then they'll say as well, I have cancer, but you can't find it. What we think is going to happen is you'll follow the patient, but you'll be able to tell them your study was positive, but it was a false positive study. And so one of the things that's very important is recognizing that false positive studies occur. And that's why there's such a challenge, and that's why imaging becomes so important. Positive study, we need to image patients and find tumors when they're very small. How do you do this? CT, MR, PET scan, other nuclear medicine studies will come back to that. But again, you could see 73% of positive cases yielded a positive cancer diagnosis in this Grail study. And you could see that they actually are building it into their process. A standardized epic order set was developed to make it efficient. And of course, one of the things that needs to be done in the future, if these studies are really to work, it needs to be ordered as easy as it is to get a cholesterol or get a lipid level or get your hematocrit or hemoglobin. And the whole process, particularly if the study is positive, it doesn't slip through the crack, but the patient is really involved in getting the additional studies. This was the questionnaire, and in this study, they used executive health physicals. So you had a little different population, patients who were really interested in detecting things early. They explained the test. They explained how the study would work. They explained some of the cancers you might find. They made the point that mammography and colonoscopy would still be necessary. We're not looking to replace those studies at this point, but this is in addition, and especially looking for the cancers that don't have a screening study. And again, telling the patients that this is early, that this is a new study. It seems to have lots of promise. When you look at the patients, the positive rate is about 1 to 2%. And again, you could see this idea about what does that mean? In about 3/4 of patients who are positive, you are going to find the cancer, as mentioned in the prior study. And one of the things is that you're going to pick up cancer often earlier. Now, obviously, these liquid biopsies can pick up stage 4 disease, but you would like to pick up stage 1 or stage 2 disease, and that's really where things are indeed going. This idea about testing becomes very important. I spoke last week at the American College of Oncology, the AACR, and the panel I was on liquid biopsy, how we're going to use it, how we're going to test patients who are positive, and how are we going to manage the entire process. That becomes very, very important. As I mentioned, the study demonstrated, this one by Ryan Hurt, 1% of patients in the population had a positive MCED test. And among those patients, you can see a range of tumors. Again, about 1/4 of the patients were followed because nothing was found. And again, we will have false positive studies, which will make things challenging, but that's always going to be the reality. And so one of the things they spoke about in this article, it was found that both primary care physicians and laypersons expressed concerns and reluctance about a study in which multi-detector or multi-cancer detection test results would not be returned to the control group. Still, they noted they were open to participation if there was transparency. The findings of the study provided insights to guide clinical trial designs and plan prospective evaluation of these multi-detector cancer detection studies. And again, it's very important. Remember, these studies right now are dealing with healthy patients. So you're really partnering with the patient. We talk about how medicine's a partnership between the clinician and the patient. So together you're working on better health. Together you're working on what studies are you going to do, and will a screening study like this fit into your process? Another comment, these results underscore the potential for these multi-cancer detector testing to complement existing cancer screening protocols, enabling earlier detection and intervention. Again, false positives, patient anxiety, cost, and integration is going to be a challenge. But if you could pick up cancer early, even if the studies right now it costs $900, I'm sure the price will come down. But even at $900, if you could decrease and save lives and decrease the patients with higher level disease and the cost they have, when you pick things up earlier, the treatment is often much cheaper. It makes things very exciting. In this article by Liang on liquid biopsies, a breakthrough technology in early cancer screening, they made the point that, again, what we like to do is there's 20 million new cases and 9.7 million cancer deaths in the world in 2022. Due to vague initial symptoms, cancer is often difficult to detect early. And so liquid biopsy would provide a minimally invasive, real-time method for cancer detection, monitoring, and characterization. So you think about it, if this works, whether you're looking at cell-free DNA or RNA, however you're doing those studies, if you could be able to change the detection rate, you're going to change everything in what we do. And in this article, they made the point of where you can get fluid, whether it's sputum or CSF, effusions, blood, ascites, bone marrow, urine, and feces are some of the common things. But again, on the global scale, when you're thinking about screening, blood is going to be the ideal source. Obviously, something like urine would be good as well if it works. Remember, the important thing is if you're screening well patients, you don't want bone marrow. That's not going to happen. You're not looking at pleural effusions. You need to think about things that way. And here's a summary of selected trials with liquid biopsy and some of the cancers. And you could see that when you look carefully at many of the trials, they have had very, very good results. Another article by Madhavan made the point about looking at two distinct approaches for liquid biopsy. One is one test for one cancer, which makes some sense if you had a perfect, really 100% accurate test, but that's not going to happen. And then you have false positives for a single test. And what are you going to have, 30 or 40 different tests? So the ideal thing, of course, and from a cost perspective and from a patient compliance perspective, would be to be able to do multiple tests. And they did a study saying, well, what if you had a single test versus a test which would look for 10 cancers, that it was more cost effective, it was more efficient, and was going to get better response from the patients. A screening system for average risk individuals using multiple single cancer tests has a higher rate of false positives and associated costs compared to a single multi-cancer test. A set of single cancer detection tests with the same sensitivity as standard of care screening detects only modestly more cancers than an MCED limited to the same set of cancers. So what they're saying is, at this point and likely for the future, the multiple cancer scheme is what's going to happen, because the accuracy is essentially the same if you developed multiple different single tests for multiple different cancers. And again, here's just some of the comments. One test, one person, where again, in this scheme, they showed that they were looking for 10 cancers. But as I mentioned now, the big MCEDs, the Galleria and the Exact Science, which is CancerSeek, is really talking about 50 to 70 cancers. And again, this comparison becomes very important, and it's something I think people recognize, and so MCEDs is really the way people are thinking. In this article by Cox, talking about pancreatic cancer, we put a lot of effort in for early detection on CT scans. Well, would a cancer detection, whether it's a single or an MCED, work? And they spoke about that. They spoke about how cancer, all the effort is going into this 5% or so of patients who have an increased family history and so increased risk, whether it's from polyposis, whether it's from BRCA2, whether it's from a Lynch syndrome or the like. But that's a small percent of cases. What about the 90% of individuals who will be diagnosed with pancreatic cancer and yet have average risk? Screening for PDAC, you can't do, all of the studies. You can't do routine CTs, routine MRs, and endoscopy. That's just not going to work. Ideally, if we can find a liquid biopsy that works, that would be very important. Now, what do you look for? You could look for pannins. People talk about that. Some studies have estimated the likelihood of pannin progression to a cancer to be less than 2% following up for 35 years. And pannins are common in patients with pancreatic cancer, but they're also common in patients who are normal, and 35 years of screening is probably not going to work. We talk about precursor lesions like IPMNs, but they're so common in the general population, 10% over age 70, up to 6% of the general population. And truthfully, when you look at MR, they'll typically say up to 30% of patients will have IPMNs. So using that as a way of following patients just really doesn't work, because you're going to be following so many patients you really can't afford to. And most of those patients will have a lifetime of tests then. Right now we talk about 10 years of follow-up for an IPMN, and 97% of the time it's going to be negative. So if you would have a liquid biopsy, the article by Cox mentions, cell-free DNA refers to DNA fragments. Fragments of cell-free DNA from healthy cells average around 160 base pairs in length and are distinguishable from tumor-associated cell-free DNA, okay? That's what you want to be looking at. Can we find these pairs, and can we do this within tumor? There's a number of different markers to look at. We talk about some of the challenges of half-life, but a lot of work is going on trying to find the right liquid biopsy for being able to detect pancreatic cancer early in a low risk or an average risk population. So again, it's very, very important. A study by Cohen in 2018 demonstrated a combined assay of CA19-9 and ctDNA abundance, demonstrated superior precision over use of any biomarker alone as a diagnostic tool for early PDAC, demonstrating the ability to detect disease in 60% of patients who had no traditional presenting symptoms, as well as 41% of patients who would be diagnosed with stage 1 disease. So you can see, if you can do this better, you're picking up early disease, which is treatable. Stage 1 pancreatic cancer has a 60 to 70% survival, not an 11 or 12% survival. So again, the question is, how can we do this? This cell shedding, the ctDNA, is something that's not perfectly well understood at the current time, but people are pursuing that and trying to learn more and more about it. And so while challenges remain in this field, again, this idea of liquid biopsy and circulating tumor DNA may provide a new strategy for early detection of an aggressive tumor like pancreatic cancer. Now, in this article by Hoffman talking about early detection, and this article looked very carefully at the patient perspective. Okay, how do we deal with patients where we're trying to explain the importance of early detection, which patients understand, but how do we explain how a screening test will work? That screening test can find the pancreatic cancer, the ovarian cancer, esophageal cancer, where there's no testing. And yes, it could also find lung and colorectal where there is screening available. But if I put together an exam that does everything, that would be really exciting. And so the impact of MCED testing, one of the questions is on adherence to recommended screening and cost to patients, payers, as well as healthcare systems are also unknown. So we need to have a lot more information before we really can make decisions on how to do things. Now, at this point I mentioned, if you want one of those MCEDs, you're going to have to pay out of pocket because it's still a work in progress. It's an emerging technology, which is very exciting, but at this point, insurance companies are not paying for it. And again, this whole process, at this time, clinicians should not feel obligated to initiate discussions about MCED testing with their patients. But a lot of patients are reading about it, and particularly patients who have the funds are always looking for new things. You can see screening MR has become very popular for some patients. There's been over 300,000 screening MRs done last year in the US alone. And again, this MCED testing is becoming very, very popular as well. So it's going to be very important how we teach our patients and what we tell them and how we deal with them together is really going to be based on how well these techniques develop. Genomics, epigenomics, transcription, proteomics, machine learning can all look at algorithms. And one of the things we talk about is how AI is going to play a major role in this entire process. And there have been studies. The CancerSeek study, which was originally the study that was done through development at Hopkins, is one of those studies. And what I'm going to do is I'm going to stop here and let's talk about CancerSeek and some of those studies when we come back for part 2 of this discussion. Thank you very much. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.